Dr. Bhattacharya, good morning.
Sir, good morning.
Good morning. Good morning.
Sir, I'm really sorry for some technical glitch. But now I can see you, so I can start.
Yes. Good morning. Today we'll have a discussion on CT scan. CT scan is very important for all postgraduate students. Either you will get a CT in your OSCE or it will be shown the CT plate and we asked to identify the normal structures and the obvious pathology. Dr. Avik Bhattacharya is a very renowned intervention radiologist in Kolkata and is a very good teacher. Is to take part in our program earlier also. So Dr. Avik Bhattacharya will take us through the triphasic CT scan, hepatobiliary pancreatic area. So Dr. Bhattacharya, you can share your screen and start.
Thank you, sir.
Okay.
So my screen is seen?
Yes.
All right. So, good morning, everyone. Today, in this next probably 45 minutes, we'll have a generalized idea how when we see a CT scan, what are the points we need to see, starting from the technical issues of doing a CT scan. We have non-contrast CT scan when we take a patient inside the CT scan gantry and we take images without giving any intravenous contrast. And then after that, when we give intravenous contrast, we see different phases inside what's going on inside our body. So why these are important? Why we do that? To differentiate different lesions in our body and the common pictures when you see a CT scan, we will discuss. So it would be an interactive session. In between the discussions, I would request you to tell us something about what's going on inside that screen. You please join, then it will be more informative and more interactive. Okay. So starting from the as it was a class for a triple phase CT scan of abdomen, we need to first figure out what does it mean. What does it mean a triple phase CT scan? Or it is also called multiphasic CT scan. Actually, different structures of our body and different pathology of our body enhances in different time interval when we see a CT scan or contrast enhanced CT scan of either thorax or abdomen of our body. So what does it mean? Suppose the vascular structures, aorta, mesenteric arteries, and all these things, celiac trunk, superior mesenteric, inferior mesenteric, they are very nicely seen in early arterial phase. Early arterial phase, it comes after 12 to 25, around 15 to 20 seconds after giving the contrast injection. So here you also try to understand the fact is that when we give a contrast to a patient, suppose the contrast volume is around 80 ml or 90 ml. And when we do a triple phase study, we inject the contrast in a volume of 4.5 to 5 ml per second. If I inject the contrast in 5 ml per second interval in this mode, everything the machine will do. We have to just calculate and we have to just fix the protocol, and then rest things the machine will do. So if I start giving a patient contrast 5 ml per second and we have to give him 100 ml of contrast, that means the contrast will go for 20 seconds. All right. And after that, after giving contrast, we give a saline chase of probably 20 to 30 ml. And that will be also going in a tune of like 5 to 6 seconds after giving contrast. So this whole 25 to 30 seconds span, we are injecting contrast to the patient, contrast, and then after that normal saline. And when I am talking about early arterial phase, it starts from 15 seconds. That means already at that point in time, we are giving patient contrast. And from the starting point of giving contrast, starting point of injection, we have started counting the seconds, and after giving after starting the contrast injection, after 15 seconds we start having our studies like early arterial phase. This is very important. It's not like that I am giving 80 ml of contrast and then start counting that now I am counting for 15 seconds. No, when I start giving contrast, I start counting. The contrast may be going for next 25 minutes, but the scanning will start from 15 minutes, because at that point in time, contrast concentration would be maximum in aorta, heart, and the vessels, the arteries particularly. So the angiographic films delineating a tiny pseudoaneurysms or aneurysms or any vascular malformation would be maximum when I take a picture in an early arterial phase of contrast study. That means in between 15 to 20 seconds of starting the contrast injection inside the body. Then comes late arterial phase. So late arterial phase means it is like 25 to 30 seconds after starting the contrast injection. And this is very important to figure out, to delineate a hypervascular tumors. Particularly, as I told, like the topic, we have to discuss the pancreatic protocol. So pancreatic protocol means this is a contrast study to delineate the smaller pancreatic tumors. See, if a pancreatic adenocarcinoma is big enough, you can see it on non-contrast CT scan also. If the pancreatic head mass is obstructing the bile ducts or pancreatic duct, you see the bile, both ducts are dilated. It is very obvious to delineate it. But if there is a small pancreatic tumor, which is otherwise not doing or not having any contour bulge, not seen on your non-contrast phase or portal venous phase or hepatic venous phase of contrast study, if we don't do a pancreatic protocol, we may miss that mass. Particularly the neuroendocrine tumors of pancreas, hypervascular tumors of pancreas, we can miss if we don't do a proper study to see that. So that's why this comes the late arterial phase. Late arterial phase is very important because in that phase, the hypervascular tumors of liver and pancreas and the hypervascular lymph nodes, the locoregional metastasis from the tumor are very nicely seen on CT scan. So late arterial phase comes at around, I said, 30 to 35 seconds. And then comes the hepatic or portal venous phase. Why it is important? Because those hypervascular tumors who are mainly supplied by the arteries, that's why they are having enhancement on our late arterial phase of contrast study. They don't have they don't have blood supply from the veins, like in liver portal veins or in pancreas. So as they don't have any supply from the veins, and the liver is mostly supplied by the portal vein, so in portal venous phase, the hypervascular liver tumors would be hypo-enhancing than the rest of the enhancing normal liver parenchyma. That's why hepatocellular carcinoma would be enhancing. That means it will be more bright than the rest of the liver tissue on arterial phase, late arterial phase, and on portal venous phase, it will be darker than the rest of the liver parenchyma. When the portal vein has come, the contrast has already infiltrated the normal liver parenchyma and it is enhancing. I will show you all the pictures just to discuss the technical details, and then I'll take you to the normal scan, how we interpret a scan, and what are the structures. I'll tell you everything. And then after portal venous phase, I said portal venous phase come around 45 to 50 seconds. The hepatic venous phase comes around 60 to 70 seconds. So all these things, as I have told, we have customized those seconds number, like all these phases according to our need, our priority. So there is no hard and fast rule in which study we'll be doing which phases of study. Suppose in hemangioma, to diagnose hemangioma, we have to take few delayed scans. But to diagnose the HCC or to diagnose a pancreatic neuroendocrine tumor, three phases are very important. First is the early arterial phase. Why? Because any surgery, if we are really going to plan on this area, like hepatobiliary pancreatic system, be it Whipple's, be it other big surgeries, we need to know the arterial anatomy thoroughly of that area to make the operation safer. So that's why the arterial anatomy, the normal hepatic anatomy, normal pancreatic anatomy of arterial system is very important for us for that early arterial phase. And then comes the late arterial phase to delineate a small hypervascular tumors of liver or pancreas. And then comes portal venous phase or hepatic venous phase, where that the rest of the tissue, pancreatic or liver tissue, stands out, and we can see the tumor as a hypo enhancing area, or probably sometimes iso enhancing, iso, the same of the pancreatic or hepatic parenchyma. So these three are very important: early arterial, late arterial, and hepatic or portal venous phase, any of these. But in hemangioma or in some type of fibrous tumors like cholangiocarcinoma and all, we need to have delayed images. And here we take delayed images starting from 90 seconds. That means 1.5 minutes. And then comes like 2 minutes, 3 minutes, 5 minutes, and so on, depending on what we are doing. We need to be very clear in our mind what lesion we are really going to see on this. So is that clear? The arterial
Yes,
timing and all. So this is a normal anatomy of upper abdomen. I am sure all of you know the different structures. Like this is left lobe of liver. This is left branch of portal vein. This is right lobe of liver. This is intrahepatic inferior vena cava. Intrahepatic. And this is aorta. This contrast enhancing is stomach, and this is spleen. This is spleen, and this is stomach. This is diaphragm. This is diaphragm. So this black thing is lung, and this thing is the cranial most section of upper abdomen of our body. Now, this is one down section, the same area where we can see the falciform ligament dividing this segment 3 and segment 4B. This is this is right portal vein joining with this is the left portal vein. Here it is joining with the right portal vein to form the main portal vein. Again, this is inferior vena cava. This is spleen, and this is stomach. Here, I would show you a video. You just please try and figure out what are the structures you are seeing and whether there is any anomaly present or not. This is a CT scan of upper abdomen, right? And here it goes. It should move because it is a video. So, well, so sir, anybody has any idea how to show videos on this platform? Can I take the normal videos from the desktop?
Yeah. That normal video will play.
This is the PowerPoint. This thing.
The same file has to have that video. Otherwise, you go to the normal video, that will play.
Okay. All right. So basically, as we were discussing, smaller tumors of pancreas can be very bright, or we can see it very clearly when we do a late arterial phase of contrast study. Here in this particular phase, you can see this is liver, this is duodenum, and this is the area of pancreas. In this pancreas, you can see a lesion, a oval lesion, which is enhancing. See, you can appreciate this is the rest of the pancreatic parenchyma, which is not enhancing. But this lesion, although it is also having a contour bulge, it is a mass lesion, is bigger than the normal width of pancreas, but it is also enhancing on late arterial phase of contrast study. If we see this type of image, we are very sure we are dealing with a hypervascular tumor of pancreas. But suppose if this enhancement is similar to rest of the pancreatic parenchyma on portal venous phase or hepatic venous phase, and this is not that this big to make this contour bulge. So if I take a plain study, that means the CECT of abdomen, suppose a non-contour study and a contour study in the portal venous phase, we may totally miss the tumor. So that is why if we are suspecting a pancreatic tumor or any hypervascular liver tumor, we have to go for a triple phase study and we have to take the late arterial phase of contrast study. Here it is, see the aorta is bright. There is no contrast inside the inferior vena cava. That means it is a arterial phase. You can appreciate that. Already the renal tissue, the cortex of renal tissue has got the contrast inside. That means this is not the early arterial phase. This is the late arterial phase study where you can see a hyper-enhancing tumor at the region of pancreatic tail. Similarly, in another patient, there is a big tumor here. This is in between the late arterial phase and portal venous phase. Here you can see the contrast in aorta as well as the contrast in the portal vein. So this is probably in the early portal venous phase, and in this phase also you can see a big tumor here, which is homogeneously enhancing on the portal venous phase of contrast study. So when we see this type of mass lesions in pancreas or liver, there the triple phase study is a must to differentiate the different types of tumor. Just one second. These videos are very important. Like, we can't show it. I have to stop and take another.
You can go to the video clips separately.
Yes,
Yeah.
sir. Yes, sir. I'm trying.
I'll be PowerPoint time होना चाहिए that video. Yeah.
So we can see that, no?
Yes.
Yeah. So basically, so anybody from this picture, can you tell us like what's going on inside? This is so this is liver. The entire thing is the liver. The all white structures at the portal veins and hepatic venous branches. We can see the different type of vessels when we suppose. So these three are the hepatic veins. If I am really struggling with this technical thing like this, if I fix it here, so this is right hepatic vein, this is middle hepatic vein, and this is left hepatic vein, right? It is draining into the suprahepatic inferior vena cava. My cursor is seen, no, sir?
Yes. We can see.
Okay. And this hepatic veins and their branches are seen in the cranial sections of the liver. And if we go down caudally, I'm going down caudally. Now you can see this is the left branch of portal vein and this is right branch of portal vein. Both of them are joining here. See here. So this is right branch and this is left branch are joining to form the main portal vein. Here it is main portal vein. This is main portal vein. Below this is intrahepatic inferior vena cava. Anteriorly this is gallbladder. This is pancreas. So all this is stomach, spleen, all structures you know. These are all familiar structures in upper abdomen. If I further go down, see we can also see the bile duct. So this is the bile duct, right? Common bile duct. You can see just anterior to portal vein, and portal vein is bright, and bile duct is a oval shaped hypo dense area. This is the common proximal common bile duct. And if we follow it down, you see we can follow it down here. Now it is here, and it is going down here. Now it is somewhere here. This is the pancreatic head, and it is going inside the pancreatic head. Now it is within the pancreatic head. Here this is bile duct, and if I go down, it is draining into the major papilla. So you can see the dark structure inside the pancreatic head. So this is the common bile duct. This is liver, I said. This is the pancreas. This is when I say pancreas, the pancreatic head is the caudalmost portion. This is the caudalmost portion. So this part is called the uncinate process of pancreas. This is the pancreatic body, which is in close relation to your superior mesenteric vein and superior mesenteric artery. These two are very important when we'll be discussing a pancreatic tumor. These two structures are very important, and we need to delineate the relation of pancreatic tumor with these structures. So just keep it in mind. So pancreatic superior mesenteric vein is it is abutting the pancreatic head. There is no fat plane in between. However, the pancreatic superior mesenteric artery has got a well maintained fat plane with the pancreatic head. Okay. So if I go down, these two are the kidneys, right kidney, left kidney. This is the part of spleen. This is part of liver, and those are the small bowel. And this is superior mesenteric artery, and this is superior mesenteric vein. So these are the normal structure. As I go down, so these are the small bowel jejunal loops, and this is colon. So this is a normal CT scan of upper abdomen. Now I'm going to a scan which is not normal, and you have to tell me where is the abnormal thing. This is liver. I'm going down. I'm going down. See, you see the portal vein is there. Portal right and left branch of portal vein is there. But alongside, there are tubular hypodense structures. You can see that. And you can also see, if I go down, so what is this? These hypodense structures are just anterior to the portal vein. Any idea?
Biliary radicals.
This is intrahepatic biliary radicals which are dilated, isn't it? So those structures like, you can see now, sir, everybody can see my screen?
Yes, it's all visible.
So these are the
This black.
structures. Yeah. It was not there in the previous scan. If I again go through the previous scan, this is the previous scan. If you see, you can only see in liver, there are hypervascular, that means bright structures. There is no hypovascular, there is no no structures which is darker than liver parenchyma. Those are all normal. See,
Yes.
the hypervascular artery vessels are there, and the normal liver parenchyma is there. And if you compare with this picture, you can see that there are hypovascular structures. So these hypovascular structures are the dilated intrahepatic biliary radicals. This is very important. We need to see whether there is IGBRs, whether the IGBRs are dilated or not. If the IGBRs are dilated, that means there has to be some obstruction downstream. So we need to see where is the obstruction, and we need to figure it out. Okay. So see, now we have to figure out where exactly the obstruction is. Now we are just following the intrahepatic biliary radicals. I'm going down, and here you can see the dilated bile duct, distended gallbladder. So this is distended gallbladder. This is common bile duct, and this is the cystic duct. It has got a low-lying insertion into mid-common bile duct. So it is gradually down. If I go down, so this is common bile duct here, here, which is dilated. Within the pancreatic head, see, the pancreatic head has started. This is the pancreatic tissue. This is the duodenum, second part of duodenum. Here, this is the distal common bile duct, which is abnormally dilated. This is not normal. This common bile duct dilatation is absolutely abnormal, what we can see here. And if I go further down, see, you can see this is round dilated structure. This is common bile duct. This is second part of duodenum. This is inferior vena cava. This is aorta. Those are kidneys, liver, gallbladder, which is distended. And further down, I could see a mass lesion here. See, this is a mass lesion at the region of ampulla. So it is you can appreciate this is the normal pancreatic uncinate process, and there is a hypodense mass lesion at the region of pancreatic ampulla, which is obstructing the pancreatic duct, which is not obstructing the which is obstructing the common bile duct, but which is not obstructing the pancreatic duct. You see, the pancreatic duct is not dilated. This is the pancreas. So it's always go up when you see the pancreatic tail. So this is pancreatic tail situated cranially. So this is a homogeneous pancreatic tissue. The pancreatic duct is not dilated. And if you follow that tissue, it is this is the region of pancreatic body. If I go further down, this is the neck region of pancreas. We can see the dilated CBD at the head region. And here comes the head region of pancreas. So this is head and this is answer process. So this ductal dilatation is only common bile duct, not pancreatic duct. And why? Because there is a mass lesion at the periampullary region obstructing it. When we don't do the contrast enhanced study, particularly the triple phase study, those lesions, the characteristic of those lesions are usually they get missed. Are you on the same page?
Yes, yes.
All right. So I'll be showing you another lesion, another picture of another case. And if you could appreciate this.
Yeah. Dilated IHBR.
Yes, IHBRs are dilated. Apart from that, apart from the dilated IHBRs, there are few hypodense lesion in liver which are not seen in the previous scan. See, this is a lesion which is a hypodense lesion in right lobe of liver. Another lesion was there in the left lobe here. So we can appreciate. I'm not sure how is the resolution. You can see it or not.
It's good. We can see.
Yeah, and there is another lesion here in segment 8. So this is right. Although it is a hepatic venous study, here we can see this is the right hepatic vein, this is middle hepatic vein, this is left hepatic vein, very faintly seen. So this area is representing the segment 8. This area is segment 7. This is 4A and this is 2 of liver. So that's the way we differentiate different lobes, and we can see in all the lobes there are lesions, hypodense lesions, which are abnormal space occupying lesions. And here alongside the left branch of portal vein, we can see the hypodense structures, tubular structures. So those are the dilated intrahepatic biliary radicals. So biliary obstruction is there. On top of that, there are few focal lesions in liver. And if I go down, see, this is dilated common bile duct. You can also see the pancreas. The peripancreatic fat plane is fuzzy. The pancreas has got a mild pancreatitis pattern. See the thickening of the, this is the left anterior paradenal fascia. This is lateroconal fascia. Those are thickened. Peripancreatic fat has got some streaky densities here. So fat stranding is there. So that means some mild pancreatitis is happening with this patient. Some biliary obstruction is there. Some focal liver lesion is there. If I go down here, I could see a mass lesion. Can you appreciate this lesion? There is a mass involving the pancreatic head and uncinate process here. Right. And this mass is obstructing the intrapancreatic common bile duct. The normal enhancement of pancreas and this adenocarcinoma has got a lesser enhancement. So this is the, like when we do a triple phase study and see the different phases, we can see the enhancement characteristic changes in different tumors of pancreas. So when we see this lesion at the region of pancreatic uncinate process and head, which is obstructing the common bile duct, we need to figure out whether this lesion is resectable or not. In that point, we have to very carefully see the superior mesenteric vein. This is superior mesenteric vein. This is superior mesenteric artery. See, the lesion is almost abutting the superior mesenteric vein. What is abutment and what is encasement? When we see a tumor is encircling more than 180 degree of a vessel, we call it encasement. If it is less than 180 degree, it is called abutment. So here in this particular case, it is not 180 degree. From here to here, the tumor is abutting the just less than 180 degree. So we would not be able to say it is an encasement because there is no contour deformity, there is no interluminal thrombus, there is no narrowing of the vessel, and the superior mesenteric artery is well separated. So probably if we see the local resectability criteria, if we have to resect a small portion of superior mesenteric vein, we are okay. Superior mesenteric artery is free. So probably locally the tumor is resectable. Now, what are the lesions in the liver? Probably in a setting of biliary obstruction, multiple focal lesions, this type of small lesions may be either metastasis or it may be cholangitic abscesses. So depending on the patient's clinical features after antibiotic therapy, whether they are resolving or not, and in sometimes MRI scores better than CT scan to delineate abscess versus tumor, we can differentiate. And still, at the end of the day, after doing all these things, if we are stuck, we are not sure whether these lesions are cholangitic abscess or a metastasis, we need to put a needle and we need to take the sample. And if these lesions are liver lesions are metastasis, then there is no point discussing the resectability. It is already irresectable. But if those lesions are cholangitic abscesses, and there is only a abutment of a small segment of superior mesenteric vein, but superior mesenteric artery is free, we can attempt for a Whipple surgery. Is that clear?
Yes.
So as we were saying, ki MR scores better than CT scan in some areas. This is a video of the same patient of this is MRI. Here you can appreciate this is the liver, and again you can see the brighter lesions in a better way. See these two lesions are there. This is one lesion, and this is another. These two, both of them are in segment 8 of liver. One small lesion is there in segment 2 here. So there are few small lesions in liver, and if we go down, there are a few more lesions here, and then we see the bright structure is the intrahepatic biliary radicals here. Just on the contrary, just I'm not telling you the technical details of MRI because it will be like overburdening in this. This is a class for triphasic CT scan, but still you need to know on MRI. This is MRI plate. This is MRI T2 weighted image. Here, all the vascular structures would appear dark, black, and all the structures containing fluid, that means gallbladder, common bile duct, or stomach, would appear bright. Right? This is the beauty of T2 weighted image, and here you can see this is aorta, black. This is inferior vena cava, and these are the portal venous branch, which are black. But just adjacent to it, these bright structures are the intrahepatic biliary radicals, which are bright. Okay. And if I go down, see, if I go down, this is the common bile duct. This is common bile duct, which is bright. This is portal vein. This is right branch of portal vein, which are dark. This is the celiac axis. This is splenic artery. This is the hepatic artery, common hepatic artery. I'm going down further. This is the cystic duct. This is the neck of gallbladder portion. This is gallbladder. This is common bile duct, and it is still dilated. Here comes the pancreatic duct, which is also dilated. This is the pancreatic neck region. And if I go further down, here I could see a mass lesion at the uncinate process of pancreas here. See this pancreas shape. If you see many pictures of pancreatic, how the size and shape of pancreas, when you see this image, in 1 second, you can say this is a mass in pancreatic uncinate process, because this bulging of pancreatic neck and pancreatic head and uncinate process is abnormal. Pancreatic head and uncinate process is not looking like this. This is much more bulging than the normal. So that's why seeing that you can say there is a abnormal mass. But when you say mass, if first you'd say ki, what about this is superior mesenteric vein, this is superior mesenteric artery, the relation, and then the liver lesions. So here you can appreciate the pancreatic neck mass. Same patient, I said, I showed you the CT scan. Multiple lesions are more conspicuous, liver lesions. CBD is dilated, abrupt narrowing at the pancreatic part, and there is a lesion which is otherwise resectable from local point of view. Then we did a diffusion weighted image. This is diffusion study, and you see, you focus on the liver lesions. See, there are so many lesions. We could see on CT scan probably 2 or 3. on MRI T2 images 4 and 5, but on
How to
diffusion
differentiate
image-
abscess versus metastasis?
Sir, that's why. So these all are diffusion restricted, right? These all are bright. Bright means you can see now the liver is also like it's looking like multiple small light bulbs are popping up inside the liver.
Yes.
So these bright lesions, again, they may be abscess, they may be metastasis. We calculate the ADC value. Here we calculate the ADC value that came out to be in the range of abscess, but still we hit the lesion, and there was a inflammatory pus, neutrophil containing pus came out. We send it to histopathology. We hit 2 lesions, and the pus came, so we thought it is a cholangitic abscess. With antibiotic, these lesions subsided. It's raining outside. So this is my one more case. And when I am going inside the discussions, I am first I had shown a normal anatomy of upper abdomen where we could see the liver, the intrahepatic vessels, then see normal common bile duct, pancreas. Then we have discussed a lesion which is probably resectable because only abutting a small section of superior mesenteric artery, superior mesenteric vein, but otherwise it is normal if those liver lesions are cholangitic abscess. Here is a different patient, a different lesion. Are we on the same page, the students? I'm going slowly.
Yeah.
I need the answer from a student. Intrahepatic biliary radicals are grossly dilated, isn't it? These
Yes.
curvilinear dilated hypodense structures are not usual. I have shown you the normal anatomy of liver, normal contrast enhanced pattern of liver, but these dilated structures are absolutely abnormal, and these are dilated intrahepatic biliary radicals. If I go down, I can see that CBD is also grossly dilated here. Sorry. Gallbladder is hugely distended, as you can see here, and the pancreatic duct, which is also dilated. So pancreatic duct is dilated, common bile duct is dilated, gallbladder is grossly distended. And if I further go down, I could see a mass lesion here. This is a big mass. It is encasing this is the celiac trunk, which is getting encased. And all the other structures also, it is infiltrating the duodenum, the antrum of stomach. If I go down, this is the superior mesenteric vein. This is superior mesenteric artery. Superior mesenteric vein is encased by the mass lesion. If I further go down, it's finished. This is the third part of duodenum. This is the third and fourth part of duodenum. This is aorta. This is intravena cava. This is if I now I am going up. Here is the mass. This is the mass which is encasing the superior mesenteric vein and celiac trunk, and it is obstructing. See, it is a big mass actually, big mass infiltrating on the gastric antrum, duodenum, and is also infiltrating. This is superior mesenteric vessels, and it is obstructing both the CBD and pancreatic duct. So it is inoperable pancreatic head mass. But I need to show you, this is the dilated intrahepatic biliary radicals here, which are not normal. See again, I have discussed the vascular structure. This is the right hepatic vein, this is middle hepatic vein, this is left hepatic vein. Those are normal structures, but these hypodense areas are the dilated intrahepatic biliary radicals here you can see, and those are abnormal. And again, the pancreatic duct you can also see. This is the pancreatic tissue here, and this hypodense tubular structure inside the pancreatic tissue is the dilated pancreatic duct, and it is very clearly shown, the dilated duct here at the body region. Sometimes, like when we don't see it frequently, those imaging, so it may be difficult to appreciate on this Zoom platform. So my request is to all students, like whenever you get time, whenever you get an access to the CT scan console, you go there, catch hold to a technician or technologist and tell him like this patient is having a beforehand, because you are treating a patient, so you know which patient has got a pancreatic head lesion or hepatobiliary pathologies. And in that case, you go there, you sit in the console, you have the mouse on your hand, scroll the images and see yourself. It is a three-dimensional thing. Once you see this type of images, you would love it, and you stop seeing the plates to diagnose a case. And this is also important for your surgical point of view also. When you are going inside, you are scared what's going on inside. If you have a three-dimensional idea of your patient's tummy, so you'll be more confident when you go in. So always try and sit with a technician, technologist. Better if you sit with a radiologist in the console of CT scan and MRI and scroll yourself with the mouse in your hand and see the structures yourself. This is very important. You can anytime, I told sir, you can anytime come to CMRI for this type of discussion. I would love to. These all are our institutional case. I can show you anytime. But you see, don't see in the plates, because the plate would not give you a three-dimensional idea. So it will be always missing. My last case of the day, and here it comes. I'm gradually scrolling from upside down, from cranial to caudal. I'm going. This is liver. And this is intrahepatic biliary radicals, which are dilated. All right. Anyway, there are two big cystic lesions. Sorry. Two big cystic lesion in liver. Here in left lobe, you could see two big cysts in liver. These are not dilated intrahepatic biliary radicals. These are hepatic cysts. One is bulging the contour of the left lobe. And if I track it down, this is common bile duct again, which is dilated. And see, there is abrupt narrowing. Abrupt narrowing. Why it is narrowed? Because there is a mass lesion. You see, there is a mass lesion. This is the mass here at the region of head of pancreas obstructing. And there are many peripancreatic lymph nodes. Many peripancreatic lymph nodes are there. So, and this pancreatic duct is also dilated at the tail region and body region of pancreas. You see, the pancreatic duct is dilated. And I have shown the common bile duct is also dilated. And both are converging here. Here is obstruction by this mass here at the region of pancreatic head. Again, we need to see first, is there any focal lesion? Is there in liver or not? No, there is no such focal lesion suggestive of metastasis is there in liver, because these two cysts are the plain and simple cysts. The metastasis can never be like this. So these are simple hepatic cysts. Intrahepatic biliary radicals are dilated, however, and there is a mass. Now we could see the mass is abutting the superior mesenteric vein around 180 degree. So probably it is encasing, but there is no contour deformity. There is no intraluminal thrombus, and it is short segment. We need to measure how much is the length of the superior mesenteric vein, and from the origin, how far it is. We can plan for dissection and end-to-end anastomosis. The artery is pretty well separated from the mass, and there are few peripancreatic lymph nodes are there.
What are the lymph nodes, and why do you look for aortocaval node?
Yeah. So again, this is the aorta. This is the vena cava.
Yes.
So this is the area of aorta cava. Aorta cava lymph nodes are always seen here, in between the aorta and superior vena cava. So this is the pancreatic uncinate process. This is the superior mesenteric vein. This is superior mesenteric artery. This is the stomach. This is stomach, and this is the duodenum. This is the colon. This is the right kidney. This is left kidney. This is the whole anatomy. So here, all peripancreatic, retropancreatic lymph node would be seen in this region, along the superior mesenteric vessel. This is pre-aortic, This is para-aortic. This is aortocaval. This is precaval. This is this is celiac trunk and perisuperior mesenteric vessels. So here in this particular patient, we have lymph nodes here. If I go up, so this is the, actually these are the encasements of celiac trunk is also encased by the tumor. And if I go down, so these are the lymph nodes here. You can see the soft tissue structure here. This is inferior vena cava. I told this is aorta. This is aortocaval lymph node. This is retropancreatic lymph node. This is the pancreatic uncinate process, and small lymph nodes here and enter to the superior mesenteric vein. So this area is very fascinating. Actually, you know better because you open this patient up and you will see when you do a Whipple's procedure. But we, like we radiologists, when we don't open the patient up in the grayscale, we see all those structures. It is really fascinating to see the lymph nodal groups, the mass, its infiltration, whether the celiac trunk is infiltrated. Another more important thing is the soft tissue sheath along the celiac trunk and superior mesenteric artery. Sometimes, a bit far away from the tumor, you will have a sheath, soft tissue structures like cuffing the alongside the course of superior mesenteric artery or celiac trunk. So this is because of the neurovascular spread of the tumor. We see the periarterial soft tissue sheath like structures. So those are again those tells you the inoperable disease. So those things are there. I think, sir. I
Yes,
think this
yes.
is question for today.
Pancreatic part is well seen. Yes.
So any question from the audience?
Yes. Anybody can clarify your doubt, because in exam you will have this. You will not. It may be shown the video also. Now in OSCE they show video also. So
This
there are
is
a lot
very
of things to
characteristic,
look
sir.
for.
Those videos what I have shown, those are very characteristic. The
Yeah.
dilated common bile duct, dilated pancreatic duct, pancreatic head mass. You need to see if there is a head mass. First, you don't bother about the pancreatic head, pancreatic duct dilated or CBD dilated. First, you see whether the adjacent critical vascular structures are free or not. For students, I am saying. First question would be like this: if there is a mass, whether this is hypervascular or hypovascular, that means it is bright to the rest of the pancreas, or it is a hypo, that means darker to the rest of the pancreas. Usually the bright tumors are the neuroendocrine tumors. The darker tumors are the adenocarcinomas. So first is this. The second is the size of the tumor. And third, adjacent superior mesenteric vessels, vein and artery, whether they are encased or not. And then peripancreatic lymph node. And then comes the liver. See the is there any focal lesion is present in liver or not. And then comes the arterial anatomy. Whenever you are going in, you need to know the normal anatomy of that area. The normal hepatic anatomy, pancreatic anatomy, whether there is a deviation present or not. Very important one we see very commonly is that replaced right hepatic artery and accessory right hepatic artery from arising from the proximal common superior mesenteric artery. So those are very important thing when we report and when we discuss with you.
In liver, sometimes you have a dilated hepatic radical, biliary radical, and how to
Yes.
differentiate this from a hypotense lesion in the liver? A
Exactly.
dilated
So
biliary
see here
radical.
in this, I as I said, in a single image, it is very
Yeah.
difficult because
Okay.
in this single section, you see these are round structures, these are oblong
Yeah.
structures. So
Yeah.
this round structure, whether this is cyst or not, we will never be able to tell. But if you see it, I am scrolling it down, you see it is getting continuous. It is getting
Okay.
continuous.
Yeah.
So that's why I'm saying don't see the film to the students. I'm saying don't see the film, see in the console. If you scroll it down, your 80% confusion would settle when you see the image on console. Those structures where you're not sure whether it is a normal structure or it is abnormal structures, everything like in when you see the X-ray, chest X-ray, you see a chest X-ray focal lung nodule on chest X-ray. You think this is maybe lesion. When you are talking about a pancreatic lesion or hepatic lesion, you see a few focal nodules in lung. So again, it is inoperable. You go through the HSCT, you say this may be the end-on view of the vessels. So when you see in console, your 80% job is done, but rest 20% would be solved by your radiologist friend.
Dr. Bhattacharya, can you have a class on October for liver lesions? Anytime?
Okay, sir.
Before
October is
Puja.
like This is last third week of September. Yeah, October can be done, sir. You let me know
Before Puja, maybe 10 to 15 anytime in this period.
Sir, I'll tell you surely.
Okay.
Because
Thank you.
I'm going to Chattogram in the first and second week of for a conference, that industry conference actually.
Okay, okay.
And I'll be coming on probably on 11th of October.
Okay,
I'm
fine.
going
After
on
that only.
4th.
Yes.
So after that we can plan, surely.
Okay. Thank you very much.
Thank you, sir. Thank you so much.
Thank you.
Thank you all.
Thank you, sir.
Thank you.